Good afternoon, everyone, and welcome to today's webinar hosted by Region 8 chapters of HFMA. The topic for today's webinar is 340B in 2018, Moving Beyond Compliance. I'd like to welcome today's guest presenters, Brad Brotherton and Brian Bell. Brad Brotherton is a member of BKD National Healthcare Group. Brad provides audit, cost report preparation, and other Medicare and Medicaid reimbursement consulting services for hospitals and integrated health systems. Brad joined BKD in 1998. His experience includes supporting clients during Medicare audits and preparing special payment requests. Brian Bell is also a member of BKD National Healthcare Group. He has more than 14 years of experience providing consulting, financial, process improvement, and regulatory services to health systems and hospitals around the country. Brian has assisted clients with all aspects of the 340B drug pricing program and has partnered with a national IT company to implement 340B split billing software for hospitals. So, without further delay, I'll hand the call over to today's guest presenters. Gentlemen, please go ahead.
Thank you very much, Nikki. This is Brad Brotherton, and thank you to all the participants for joining us this morning to talk about a really relevant and timely topic of 340B. I kind of envision today's discussion really being a 340B 201 or 301 type of topic. A lot of the introductory or basics of 340B we're not going to spend a lot of time on. There's a lot of presentations and information from groups like 340B Health or 340B University that go into a lot of the compliance basics and some of that type of information, but really hoping today that we're able to talk some about some incremental strategies and optimization type of techniques available with the program, as well as get an update on where some of the regulatory environment around 340B may be. Really happy to have Brian Bell joining me today. Brian works on 340B items and issues pretty much all year, all throughout the year, and really joined us after years of implementation and strategy assistance for a large national split billing company. So it brings that experience and depth to BKD, and we've been appreciative to understanding a lot of those deeper strategies. So I'm looking forward to hearing that today. We do have an agenda that is going to go through some of the overview, just to level set everything and talk about some of the 340B compliance basics. We're going to move through that very quickly because I want Brian to have plenty of time to spend to discuss on topic number 4, the split billing software and 340B strategy. Then we're going to wrap up looking at the legislative changes that are out there and then where the outlook may be going for 2018 and then beyond, and hopefully leave some time for some questions at the end. So please feel free, as you hear something through today over in the chat box, please do drop in some questions that we can get to. I want to just briefly discuss BKD. We are a CPA and consulting firm based mostly with a footprint in the heartland of America, but we do work with 340B covered entities and healthcare clients all across the country. So really see a wide swath of activity and what's going on in various regions. We have been working in the 340B program for many years, and the program has really been around for a little more than 25 years. And as everybody probably on the phone realizes, this is an outpatient drug discount program. We spend a lot of time working with hospital covered entities as well as some of the grant clinics and other program covered entities. But a lot of what we're going to talk about today is really focused on the hospital setting and the split billing type of setting around those strategies. The average savings that typically is reported is somewhere between 25 to 50% on the outpatient outpatient drugs. Really what we're seeing as far as where Medicare has estimated that, as many are aware of in the recent payment changes, is around 28.5% being that discount, at least what they're applying for overall reimbursement cuts. One of the challenges, or one of the discussions that's really been top of mind, is the idea of how are covered entities using the 340B savings. And over the years, there's been a lot of different discussion or interpretations on this, and really it's been left up in many cases to what the covered entities are putting in their policies and procedures. But a lot of times we see that does provide some discounts on those drugs to the patients, or we see that the covered entities use the savings to expand the services, to provide more services to the patients, or being able just to serve more patients in general. And that is very typical. The majority of the clients that we work with do use the savings from the program to really continue to operate the hospital, to operate the emergency room, to subsidize losses that are coming from other community service type events or other things that may be needed in the area but do not provide revenue that cover the cost, and so that is very typical. But that is something that continues to be looked at and explored and challenged by Congress, and we'll talk a little bit about that in the end when we talk about some of the regulatory environment that we're seeing. 340B compliance has definitely been the subject of many webinars and other educational programs talking about each of these areas. There's many pillars of compliance that surround 340B, and I think many of the people on the phone probably have a good understanding of how you qualify, who is deemed to be a patient, how we avoid getting duplicate discounts, all of that. So we're not going to spend time today going through each of these, but do understand that 340B, because of the significant discounts that are received, is an area that comes with it heavy compliance concerns. And HRSA has realized this. It took HRSA several years to realize that they needed to really begin doing a cohesive and organized audit approach for probably the first 15 to 20 years of the 340B program. There was very little auditing that was done by HRSA, but they have definitely ramped up those items, and both on their audits that HRSA is doing, and then also on their expectation that all covered entities should be doing some independent auditing on their own, even if they're not one of the selected facilities each year. Kind of as you go across the top of these bullets, there's some interesting comments that HRSA has made over the years. The first one kind of rings true in that it says, HRSA believes that covered entities that do not regularly review and audit contract pharmacy operations are at increased risk for compliance issues. And I know in our experience in working with our clients and on our independent reviews of the compliance, definitely see this as well. So independent audits and internal audits are definitely expected to help organizations comply with all of those earlier pillars that we showed on compliance. HRSA continues to deploy resources at a high level toward the 340B program. Every year they're trying to do about 200 audits. They've been at that level since about 2015. They have most of the 2017 audits wrapped up, and a lot of those made publicly available. So if you're interested in how the facilities are faring under the audits or what some of the findings may be, that information is available for about 3/4 of the audits from 2017 out on the OPA website. So feel free to go and look more at that. But they do expect to continue to keep auditing at the same level, increasing FTEs within the OPA program, actually even outsourcing the audits on some of those to the Bazell Group into the future. So we continue to see that compliance remains a focus for HRSA and for covered entities working on their own. There's also the ability for manufacturer audits to occur, where manufacturers may reach out to HRSA and ask to do an audit of a covered entity. These typically occur after a manufacturer has not been able to resolve an item directly with the covered entity. So the typical flow of information is that the manufacturer may have some questions or may see something in their data that indicates that there may be a compliance concern. Maybe that's on duplicate discounts, maybe that's on the definition of a patient, but they may reach out to the covered entity and say, we would like to review some of these transactions. In every case, we do encourage covered entities to cooperate and work with the manufacturers, trying to resolve the issues or the questions before the manufacturer would go to the point of needing to request HRSA for permission to do an audit on the covered entity. Oftentimes, the issues can be worked out before it gets to the manufacturer audit guideline type of process, but it's important to pay attention to all that correspondence and try to work through that in advance. There are consequences for non-compliance. The most common that's going to occur in almost every case that I have seen is really repayments being negotiated with the manufacturers. A lot of the HRSA audit findings that are publicly available, the corrective action plans, often do involve negotiation of several repayments. But there's also other consequences available that HRSA may have if they feel that it necessitates that, such as ultimate removal from the program or even other liability type of issues that they may bring towards the covered entity. And so with that, I want to turn it over to Brian. It kind of gives a background of where we're at, a little bit of the 340B program at an accelerated level. But I want to turn it over to Brian to really start to talk through some of the 340B strategy items that we've been tracking.
Great. Well, thanks, Brad, and thanks everyone for joining today. I'm going to jump into this first slide, and really your 340B strategy is critical for maintaining compliance and optimizing your 340B drug pricing program. As Brad has discussed, you know, compliance will always be the cornerstone of the 340B program. The operations of a 340B program must be at the top of mind for pharmacy, hospital leadership, finance, reimbursement, and IT. And I think IT, it's important to remember that they're a very critical component of the of the 340B program with the way it runs. We recommend that covered entities develop a 340B steering committee to drive the program in a successful direction. Conducting reviews and meetings by these key stakeholders are a key component of a covered entity strategy. Your strategy must also provide the means to keep up with the legislative changes and compliance needs. It's more important than ever to protect your current savings and expand your program when possible. Brad, if you want to move to the next slide. Perfect. Split billing vendors are utilized to manage a covered entity's replenishment model. The entity tracks data feeds such as inpatient or outpatient status, patient and prescriber eligibility, clinic location, Medicaid status, drug identifier, and the quantity dispensed, and then sends this data into the split billing software. This software uses logic based on configurations chosen by the covered entity to virtually separate 340B from non-340B transactions after they occur. The software then determines from which account each transaction should be reordered. The term split billing is used to describe the software which splits a purchase order into 2 or 3 different accounts. This software can help the entity place orders in appropriate accounts, which should help support 340B compliance while allowing the hospital to only have one physical inventory. The covered entity receives discounts based on the drug utilization by covered outpatients. Retrospective procurement is used to realize the discount based on the drug utilization. I've listed out many of the split billing vendors on this slide for your reference. Accumulator or split billing software maintenance is a key aspect of a covered entity's 340B strategy. Contracting with a split billing vendor isn't enough. 340B providers must make it a priority and put the right resources in place to regularly review and look for opportunities within their split billing software. The crosswalk is one of the most important aspects in a split billing software and the means by which drug utilization is converted to 340B accumulations, which lead to be able to purchase at 340B pricing. The purpose of the crosswalk is to record and organize utilization for every NDC being used and purchased by the hospital. Each NDC must be matched to a charge code in order to generate 340B accumulations. The crosswalk is a table connecting multiple pieces of data, such as your CDM numbers, NDC, vendor, and then the multiplier. The multiplier will be defined as BUPP or units of measure or another name depending on your split billing vendor. Your crosswalk can be thought of as a funnel that basically funnels all of your utilization and purchase history and matches it up with your drug dictionary to lead to these 340B accumulations. During software implementation, much time is spent on the crosswalk, as many of you know if you went through the implementation process. Errors in your existing NDC to CDM matches and multiplier can cause high or low accumulations. Unmatched CDMs or NDCs will also lead to purchasing at non-340B pricing. As you purchase new items or create new charge codes, it must be a priority to get these matched. It is recommended to maintain the CDM to NDC crosswalk at least on a weekly basis, but we would recommend looking at it at least on a daily basis to make sure that those unmatched items are being matched. On a monthly basis, random testing and validation should occur around the crosswalk. On a daily basis, we're pulling data from our electronic health record and sending it to our split billing vendor. At least on a biannual basis, 340B providers need to validate the data sources and queries to confirm that the right data is being sent to the vendor. This is important to remember, especially if new 340B locations are added or terminated. For contract pharmacies, it is important to validate that an accurate prescriber list is being loaded on a regular basis. It is also important to maximize your data sources in identifying the exact time of dispensation. For example, if you have an ER or observation patient that is later admitted, the drugs dispensed during the patient's time in the ER or observation are 340B eligible, and this is a big opportunity to capture 340B savings. Typically, hospitals will utilize an ADT feed to capture the exact time of dispensation to avoid missing out on these opportunities. Purchasing trends can often paint a picture of if you have issues with your 340B purchasing. As you review your 340B program, you will develop known baselines for your 340B and non-340B purchasing percentages. In the case where either of these percentages increase or decrease significantly, that will be a red flag to review or correct an issue quickly. During implementation, rules and filters are set up in the software, and to be quite honest, often they're forgot about. It's important to understand the filters and how they impact the qualification of 340B drugs, especially for contract pharmacy arrangements. Based on the rules that you set up for these arrangements, they may be too restrictive or not restrictive enough based on your specific scenarios. Some split billing vendors are now adding a new opportunity to qualify drugs in contract pharmacy arrangements based on a new location feed. This is a good opportunity for many covered entities. It is also important to review your filters regularly to confirm that you're carving in or carving out Medicaid appropriately. Knowing and reviewing your reports and what they actually mean is another kind of key process to for your 340B strategy. It can be overwhelming as to which reports are meaningful to your organization. 340B savings will be an important report for leadership, but will also be important to determine which other reports, such as purchasing, especially non-340B purchasing, as well as other reports that are available, such as unmatched crosswalk reports. Your 340B accumulations report will be the report that is reviewed most often. This report alone can point to opportunities or issues in your software. This report will show where you have high positive accumulations or low or negative accumulations. Both high and negative accumulations could be due to an issue with your crosswalk. High positive accumulations could lead to over-purchasing on your 340B account. A negative accumulation means that you have purchased on your 340B account more than you've accumulated or utilized. We see this occurring when historical accumulations are loaded into your split billing software. We also see this if your buyers do not punch out while ordering, meaning they manually order on the 340B account instead of allowing the split billing software to split the order. Pharmacy buyer education is something that is often overlooked. A lot of the time we hear the same line of, that is what we've always purchased. There's many opportunities to purchase drugs at lower price based on the accumulations and what's available. For example, savings could be recognized just by purchasing at a different package size opposed to the package size that was purchased historically. It is important for the buyer to understand the 340B program and know how to research available accumulations and pricing in the split billing software. For many hospitals, they'll see on their dashboard that their potential savings are very significant. In some cases, these savings are accurate, but in some instances, this reported number is inflated due to a number of factors. If your accumulations are not accurate, the potential savings will be inflated. For many of the chain retail pharmacies, we're seeing a common trend of them either owning their own split billing software or partnering with one of the split billing vendors. For example, Walgreens owns their software and requires covered entities to use this software if you participate in an arrangement with Walgreens. Walmart has a relationship with MacroHelix. And one of the most current changes will be with CVS. They have recently acquired WellPartner. They've sent out a letter to many of their hospitals that they contract with, stating that if you're going to continue to participate in the arrangement, that the covered entity will be required to use WellPartner. Multiple split billing vendors for covered entities are becoming more and more common. This can play a huge role in your 340B strategy. It requires covered entities to learn and understand more than just the split billing software that they chose during vendor selection. Many providers are going through electronic health record conversions or recently have gone through a conversion. As you change to a new system, we know that this can be a trying time for you as a provider, as these implementations are very, very complex. Once these implementations occur, a billing conversion will need to occur with your split billing vendor. In some cases, the conversion isn't as time intensive as the initial implementation. This is largely based on if your CDM numbers change. Oftentimes, for example, if you change to Epic, your CDM numbers will change, which means you'll need to rebuild your crosswalk. Data feeds will also need to be rebuilt during this conversion. These conversions can be a time of non-340B purchasing based on your existing accumulations. This is important to consider for budgeting purposes and resource planning to know that you need resources in order to complete this conversion. Next slide, please. Split billing software is just one aspect of your covered entity strategy. Your approach will be critical for you to meet your 340B goals. Your approach will include how you audit and test your progress in compliance with the 340B rules. Internal testing is an area that we receive a lot of questions. As you complete your internal testing, it's critical to do it in a way that is meaningful and trackable. What is the frequency and sampling that works best for your organization? We have clients that audit on weekly and monthly basis. Your organization will need to select a frequency that creates a process that's meaningful for you. It is important to cover all areas of your 340B program, but also have laser focus on those areas that can create the biggest compliance concerns and opportunities for 340B savings. It is important to focus on those areas that have high-cost drugs and are critical to your 340B savings. While all areas must be reviewed and maintain compliance, we know that there are some areas that can be detrimental to your program. We are seeing many covered entities that include 340B as part of their internal audit plan. While the 340B team will regularly be reviewing the program, the internal audit function will add another layer of compliance to the process. Your 340B team will have a role in this process. In addition to your internal reviews, it's important to have an independent, external, operational, and compliance review. These reviews will give you a fresh set of eyes looking at your program. These independent reviews are often the tool to connect the dots and find additional opportunities or assist with compliance issues. There are a number of areas that are most commonly overlooked and opportunities for long-term optimization. For many covered entities, there are opportunities based on the registration type. For DISH organizations, there are opportunities to purchase orphan drugs on their 340B account and reduce their WAC spend. For rural referral centers, sole community hospitals, and critical access hospitals, there's opportunities to obtain special pricing on orphan drugs. These entities are not required to have a WAC account. Orphan drugs have been highly debated by HRSA, the courts, manufacturers, and covered entities for many, many years. Manufacturers are not required to provide 340B pricing for covered entities registered as a rural referral center, sole community hospital, or critical access hospital. But those manufacturers may, at their own sole discretion, provide 340B or 340B-like pricing on these drugs. Some manufacturers, such as Janssen, are providing 340B pricing on drugs such as Remicade. While not all manufacturers are willing to provide this special pricing, it is a big opportunity to work with your manufacturers to obtain this pricing if possible. If you are able to obtain 340B pricing for orphan drugs, make sure that your settings are set in a way that allows you to purchase the drugs at the reduced pricing. I've run into this issue with clients where they have been granted the pricing but not purchasing on the account due to the way everything is set up. If you're unable to obtain the 340B pricing for some of these drugs, it may be worthwhile to discuss biosimilars with your prescribers to see if there are other options. I'm seeing this more and more with covered entities becoming creative with looking for the best option in regards to cost and what works best for their patients. Also, for these providers that are subject to the orphan drug exclusion, a plan needs to be in place for applying the required JG modifiers to reduce Medicare reimbursement. For rural referral centers and sole community hospitals, except for rural sole community hospitals, the JG modifier is required to be applied to status indicator drugs that are 340B eligible. As you review that status indicator K list, many of those drugs are orphan drugs. If an orphan drug is not able to be purchased on the 340B account, then the JG modifier is not required for these providers. Direct purchases are another opportunity for many providers. All of you purchase from a direct vendor such as FFF, Hospira, or Baxter. All of these purchases, if they meet the 340B eligibility requirements, are eligible for 340B pricing. If you currently only have a non-340B account with these vendors, you can recognize additional savings by setting up a 340B purchasing account with them. Contract pharmacy arrangements are another area to expand 340B savings. Many of you probably already participate in these arrangements. Cost savings can be achieved for all 340B qualified patients. Savings in many cases can average 30 to 40% and are a win-win for both the covered entity and the retail pharmacy. The cost savings is realized and the revenue is received by the hospital without any additional investments in personnel, equipment, or infrastructure. The retail pharmacy in exchange receives an agreed upon dispensing fee and their drug utilization is replenished by the covered entity at 340B pricing. For those of you that have already a developed contract pharmacy plan, have you reviewed what those contract pharmacy arrangements look like lately? Are there some arrangements when comparing and looking at the transaction fees to qualify, and with the increase of dispensing fee, it is no longer a valuable arrangement? Contractual arrangements carry many different variables. For example, in some arrangements, the retail pharmacy will only qualify brand-only drugs, or those that are winners for the retail pharmacy. Dispensing fees with some retail pharmacies are increasing and once again may not be a good fit for both parties in the arrangement. On an annual basis, a covered entity should review reports and complete a calculation for each contract pharmacy to determine if the arrangement is still beneficial to both parties. As you're completing these calculations, don't forget to include the cost of compliance and the other resources that are required for running the program when calculating the cost of supporting the 340B program. This will also be very important as we build out the reports for proposed legislation if it does pass, because we need to make sure that we're including all the different pieces, not just charity care or uninsured. If you're a hospital that currently carves out Medicaid, otherwise you don't purchase 340B drugs for Medicaid patients, depending on your state Medicaid 340B rules, you could expand your 340B savings by carving in Medicaid. Each state has different requirements for hospitals that carve in Medicaid. Some require the application of a modifier to identify these drugs to prevent duplicate discounts. Some rely solely on the Medicaid exclusion file, while there's other states that require 340B entities to bill differently when you purchase a 340B drug for a Medicaid patient. And we've done some calculations with clients, and we have some clients have chosen, even though they have to bill less in order to carve in, the 340B savings still outweigh this reduction in reimbursement. The addition of child sites, so those locations at a different physical address than the parent, can expand your 340B savings. If you have new hospital outpatient departments, they must be registered in a timely manner and set up in the data feeds to recognize savings in addition to registering as a child site. Child sites often lead to an increase of contract pharmacy prescriptions as well. Much of the new legislation, which Brad will discuss, will limit new child sites for DISH if passed. If you're a DISH, now is the time to add new child sites if this is part of your strategy. Also, if you're registered as a different registration type, such as a rural referral center or a sole community hospital, and not a DISH, and you meet the DISH requirements and have been debating on changing your registration type, now would be the time. You might ask, why would you change to a DISH with all this additional scrutiny? And really the main reason would be to be able to receive the 340B savings on orphan drugs. With the new proposed legislation, if passed, this opportunity could slip away. Brad is going to discuss the proposed legislation next. With legislative changes brings the need to expand and optimize your 340B savings in a compliant manner in order to offset changes such as reductions in reimbursement. Many of the legislative changes also call for additional transparency. Additional transparency is another part of the strategy that covered entities will need to focus. There will be an additional need to understand the reports and make sure the governmental reporting requirements are met. As you think about your approach to your 340B strategy, I hope some of these were valuable ideas. I'm now going to hand it back to Brad to discuss the current legislative landscape in DC.
Brian, thanks very much for going through a lot of that information. Yeah, I think one of the keys that I take away, as you've touched on each of those areas, is really the need for involvement for many different parts of the hospital to really be paying attention to the 340B program. I heard lots of areas around charge master opportunities, around pharmacy buying opportunities, around reimbursement and cost report preparation type of areas, and really a team that builds all of those different skill sets together to help look at the 340B program seems to be what it's going to take to take advantage of a lot of these opportunities. So I really appreciate you going through that. And if there were any questions for Brian, we'll have some time at the end. So feel free to drop that into the chat box. I do want to talk just a few minutes about really where 340B seems to be heading. This slide really shows some of the transformations since 1992 when the program was first put in place. It looks like there's been several changes, but what's interesting is that almost all of them have really happened, the significant ones have really occurred after 2010. The significant issue that happened in 2010 was really the expansion of the ability for covered entities to have multiple contract pharmacy arrangements. Prior to 2010, a covered entity was allowed to have one arrangement, but you had to choose. You had to choose maybe that one Walgreens store or that one local retail pharmacy. But in 2010, it allowed multiple arrangements to be put in place, and that dramatically expanded the program. One of the items of interest that's really not on this slide, but also was critical to the expansion of the 340B program, was between 2000 and 2010, and I'm roughly going to say around 2006, if memory serves me right, that prior to that point in time, rural hospitals were not able, in many cases, to have a disproportionate share percentage over 10%. There were certain types of hospitals, specifically rural referral centers, that could have a higher DISH percentage than 10, but most facilities in a rural area were limited to that 10%. Well, as many know, the 11.75% DISH qualifying criteria was still in place, and there were none of the options for rural facilities at the lower level. So this meant that many rural hospitals were precluded for many years from joining the program. Well, CMS made a change to the cost reporting regulations that allowed that 10% cap for rural facilities to go to 12%. And so while it was not a necessary change for 340B or 340B regulation, it was a CMS change on reimbursement that allowed a lot more rural facilities to go into the program. So we saw a big expansion, and whenever there was a big expansion in the savings, we definitely saw the focus of the drug manufacturers wanting to make sure that the discounts that they were giving to the covered entities were appropriate and for the right reasons. The changes with 340B have continued on that same path. As many of us know, back in 2015, there was the first draft of the mega guidance that was released that has not been finalized still, and actually has been withdrawn in 2017 by the Trump administration. And then we've continued to see further changes, with one of the largest being what occurred and started being enforced on January 1st, which was the reduction in Medicare payment for drugs that were acquired under 340B and the modifiers that are now in place. And there's continued to be some other changes. The PAUSE Act that was introduced in the House back in December, a similar act to that, the HELP Act, introduced in January, that was similar to the PAUSE Act, then introduced into the Senate. And then here at the end of February and rolling into March, Senator Grassley's Act, talking about further transparency into the 340B program. So the pace of change and the pace of items being introduced for potential change continues to be at a very quick level. I think many on the call are aware of the large change that happened on January 1st. Brian mentioned about the JG modifier, that if that is on the claim to Medicare, there will be a 28% reduction in that reimbursement. Now, what is important, and kind of the last bullet point in this, is that rural sole community hospitals, at least for 2018, which is all that they have guaranteed this to be the case for, but for 2018 are not subject to that 28% reduction and need to put the TB modifier in place. So regardless of how the facility registered with OPA, there are many sole community hospitals that may have registered with the Office of Pharmacy Affairs as a DISH provider, but are also a rural sole community hospital. They are not subject to that 28% reduction, even though they registered as a DISH. There are several concerns with the final rule, and there's actually a lawsuit that's going through the proceedings between AHA and several member hospitals about this 28% cut. There is a next hearing date for that is set in early May, so there's no conclusions on where that is going, but for right now, hospitals are living with the reduction. There may be legal challenges and changes to that that do occur, but for now, that 28% cut is in place. As many of you know, there's a large administrative burden, realizing for some facilities that may have some claims that need the JG modifier, others that need the TB modifier. Keeping up with that is very challenging. The fact that the cost reports that CMS uses to set future rates as a basis already contain the lower 340B costs was definitely a concern that was cited, as well as the savings from the reduction of 28% are being redistributed, taking away from 340B hospitals and giving those funds to non-340B providers, and even including those facilities that may be for-profit facilities as well. So a lot of challenges with this rule that's now in place. There were several frequently asked question responses that were given by CMS. There's a nice table that's part of those FAQs, and if that's something that you've had questions about, please go out and review that information more closely. One of the items that is interesting in the final rule that went into place for OPPS on January 1st is that the 28% reduction does not apply to those off-campus provider-based clinics that did not get grandfathered status. So you may remember that over the last couple of years there's been focus on new off-site campus providers, off-campus providers, and they had a reduction in their reimbursement, further reduction from 75% down to 50% this year. But one of the silver linings for them may be that they do not have to take that 28% reduction if the drugs are administered in those clinics, at least for this first year. So it's definitely something to pay attention to. If you do have non-grandfathered clinics, you may want to review if you are putting the JG modifier on those. That may be an opportunity to look at because that was not required in this first year. As I mentioned, AHA and many hospitals challenged the rule. It still is being challenged and working through the court proceedings, and hopefully have more direction on that as we head into the summer months. Also, in last summer, there was a definite focus and time of questioning of several members of the covered entity community by the Congressional Committee on Energy and Commerce. They brought in 5 members from covered entities and asked them very pointed and sometimes difficult questions. In general, there was overall support for the 340B program, which is very good. But one of the things that was interesting was really it seemed to be a change on the focus of compliance. For the past several years, there's been, the audit compliance focus, really making sure that it's only going to eligible patients and matching up with various interpretations. But the focus on compliance appears to be changing to really beginning to look at the intent of the program and how the savings are being used by the providers. We'll talk a little bit more about that under the couple of proposed legislations at the House and the Senate level. When the Congressional Committee invited these 5 members to come before them, they sent them a list of many items that they needed to provide statistics on. A lot of the information may have been more readily available than others from the split billing software, things like breakdown by financial class or the savings from the GPO, how much is 340B really meaning to the organization. But there were others that were more difficult, splitting the 340B purchases by the different types of drugs, how many were for oncology versus anti-diabetic. Those that may have been more challenging for the hospitals to provide. As well as really the last one, that if facilities really were not prepared in advance, may have taken some time to really quantify, and that was, how do the uninsured and the underinsured directly benefit from the 340B program? In the areas that the congressional members seemed to really focus in on and like were the ones that were actually passing the discount on the drugs along to the patients themselves. They didn't at times always like as much the ability of facilities saying, you know, we use the savings to continue to operate the hospital or the covered entity. Even though that's going on in most settings around the country, they were really fine-tuning and really looking at how were the patients getting access to the drugs that they needed at a much reduced price. So it gave a little bit of insight into their thinking there. After that hearing, they did release their report and had several interesting items in it about a focus on increasing and overseeing the 340B program, talking about the need for independent audits within the covered entities. Really, one of the items I thought that was very interesting was the last one, which was really looking at whether the qualifying criteria for hospitals on the disproportionate share percentage continues to be the most appropriate measure. And so we all know that hospitals cover or qualify at either an 11.75% DISH, or if they qualify under some rural criteria, they could have an 8% DISH. But that DISH measure is an inpatient measure. It's looking at patient days. It's looking at percentages of SSI patients on an inpatient basis. But the 340B program is an outpatient program, and so it doesn't really make sense that we use inpatient metrics to allow eligibility for outpatient programs, and that may be something that we continue to hear more about, is really challenging qualification measures for 340B. Back in December, there was an act that was introduced in the House called the PAUSE Act. A couple of the key things that were put in place here was a 2-year moratorium on new DISH qualifying hospitals. That same moratorium was not put in place if you could qualify as a critical access or a sole community hospital or a rural referral center. But it was a 2-year moratorium on new DISH qualifying providers, as well as a 2-year moratorium on adding new child sites for DISH entities. And so I know we're nearing the end of our current registration window when we have the ability to add new child sites. And so if there's some that you've looked at and thought, you know, maybe someday we need to add that child site, but we'll wait till there's more activity, or it's not a significant area yet, so we haven't really registered, you may want to go ahead and accelerate the timeline for getting that child site registered if you can, if it's been on your cost report already, and get that, because there has been discussion both in the PAUSE Act and in the HELP Act that we'll look at about some pending moratoriums that may be in place for a while. Also, along with the PAUSE Act were some new data reporting requirements, trying to increase transparency with the program, and then also trying to put some teeth into some of the government official contracts. The not-for-profit qualifying covered entities have to have a government official contract, and there may be some more concrete and finite language that gets added into those as part of some of the discussions with the PAUSE and the HELP Act that we'll need to pay attention to. The HELP Act was very similar, talking about prohibiting new enrollments, looking at different reporting requirements, all of these things very similar. But the last comment on here, the last bullet point, is one that I want to read. It says, the 340B program is an important resource for hospitals serving low-income areas. But too often, the program's discounts are used to pad hospitals' bottom lines instead of helping disadvantaged patients afford their treatments. This bill will increase transparency and accountability and help ensure these discounts reach the patients. And so I take from that that everyone who's working in a covered entity or with a covered entity needs to be able to appropriately state their story about how 340B is impacting their community, how it's impacting their facility, and how the indigent and the uninsured or underinsured are benefiting, how their health is benefiting, how those patients are benefiting because the 340B program is in place, and that it's not just being used to pad bottom lines, but being used to improve the health within the communities. As much as facilities can be prepared for that, be telling that story, be ready with that information, is something I think that's going to be critical into the future. As we turn our attention to the future and really looking at the outlook for 2018, 2019, one of the items that does give some insight into that is the proposed presidential budget. And in the presidential budget fact sheet, it indicates that the program is to ensure that the benefits of the program are used to help low-income and uninsured patients rather than subsidized providers or cross-subsidize the care they provide. And that goes back to that comment that I had before. There continues to be increased focus on this, increased focus on how providers are utilizing the funds from the savings of the 340B program. The presidential budget did have some increased reporting on the savings, and that was very similar to what Senator Grassley's proposal through March has also been, increased transparency there on the savings. There was also some discussion about modifying how the 28% savings pool was being reallocated out to all of the other facilities. This proposal was really to reallocate that based on uncompensated care. So it sounds very similar to S10 for many of us that work with Medicare cost reports. So maybe another purpose for S10 may be out there, as there is an ability perhaps in the future not to just allocate all of the 28% savings back out to everyone based on their Medicare outpatient volume, but maybe based on their aggregate amount of uncompensated care. And then oversight of the program does continue to be a focus on the program. There's increased user fees that have been discussed in this proposed budget. I don't have a lot of specifics on what that is, but it definitely shows that compliance and oversight will continue to be something that providers continue to deal with on a daily basis. So, yeah, that's really what we wanted to cover today. I want to turn it back over to Nikki to see if there's any questions and wrap up our program for today.
Great. Thank you so much, gentlemen. Wow, a lot of great information. So thank you, Brad and Brian, for collaborating to share this information with our attendees. Before I take our first question, just wanted to remind everyone to type their questions into that questions chat panel, which is located to the right of your screen, and we will take as many as time will allow. There have been a few questions about the slides, which you do not have to wait for. Also on that right panel, there's another section called handouts. You can click there to get access to these information-rich slides. And the replay, this has been recorded, so you will have access to that as well. All right, so let's jump right on in here. Okay, the first one is, when do you expect the proposed legislation to be passed for 340B?
Brian, I'll jump in. Definitely comment if you have some further insight. But I think what they must be talking about here are the proposed HELP and PAUSE acts. I think it's difficult to know when that will be finalized, but I would expect perhaps sometimes later this summer, in the later part of the summer would be what I would be expecting, but definitely that can change basically day to day. Brian, do you have any other insight into that?
Yeah, I would agree. I mean, based on what I've heard, it is towards the end of summer, and I've also heard this concept of the Energy and Commerce Committee is going to allow Congress to create some of these different bills, and none of them may pass, but there may be a series of bills that come out of the Energy and Commerce Committee. So it'll be interesting to see how these pan out, but I would expect, towards the end of summer.
All right, thanks for that. The next question is, you spoke about direct vendors. Are you able to split orders with your split billing vendor?
Yeah, and I can take this one, Brad. So in many cases, this will be a manual process. Typically, the savings kind of, outweigh the need for worrying about it being a manual process, and in most cases, it wouldn't necessarily be a manual process that you need to complete daily. Most of the split billing vendors have the capability to manually upload purchasing for these direct vendors to decrement the accumulations. It is important to review the accumulations prior to purchasing on a 340B account for these vendors. In some cases, you can create a mock order within your split billing software to see where you can purchase on your 340B account. And in most cases, if you do hit submit, even though it doesn't really create an order to the vendor, it would decrement your 340B accumulations as well.
Okay. Thank you for that. And in a similar vein, this question for Hollis reads, our split billing vendor recommended we turn off generic splitting due to HRSC NDC to NDC interpretation. We do a replacement model, so how can we then capitalize on savings with brand changes?
Brad, do you want to take this one, or you?
Why don't you go ahead, Brad?
So I guess we'd have to, truly understand how and why they're switching to only the brand, understanding that, some contract pharmacy arrangements do require that, and understand also that, the NDC matching. But I'd probably need a little bit more information to, think through, the why and how to maximize on that. And that's definitely something I'd be willing to discuss, after the webinar.
Okay, great. Fair enough, Hollis. So they have graciously provided their contact information, so I'm sure they would appreciate that follow-up. This next question from Holly is, where did it go? Okay, how is the 1% of the cost for uncompensated care measured?
There wasn't any specifics that I saw related to that. The best measure that's publicly available that I think may be used would be the S10 information that computes uncompensated care on the Medicare cost report. May be an area that you would measure that cost compared to what your net revenue is to see if that 1% is exceeded. But that's just speculation on what they might use.
Okay. All right. Well, guys, I am going to go ahead and wrap it up out of respect for everyone's time. There were certain questions, and there were really good ones that we could not get to. But again, both Brian and Brad have made their contact information available to continue that conversation. So as we approach the top of the hour, I want to take this time to thank our members and the healthcare community for joining this call. As you exit, you will be prompted with a survey, and we would really appreciate you sharing your feedback about today's event as well as other topics you'd like to see in future webinars. We hope you can join us on May 15th for Region 8's next webinar installment. And thank you once again to our guest presenters, Brad and Brian of BKD, National Healthcare Group. Thank you, gentlemen.
Thank you, everyone, for joining us today, and look forward to hearing from many of you in the future.
Great. On behalf of HFMA Region 8, thanks again for joining everyone. Have a great afternoon.